Ladies and gentlemen, good morning and welcome to day 2 of the conference. It's a beautiful day outside and we have what promises to be a fascinating day here inside. Coming up later, we're going to hear from various bosses, not least Sir David Nicholson, with what will be his last speech to conference. We're also going to be hearing from the boss of Monitor, Dr. David Bennett. Who is going to be talking about the various advantages of his new roles, his various new roles. First, though, let's hear from, the reason you're all here, the political boss. Please welcome the Health Secretary, Jeremy Hunt.
Good morning, ladies and gentlemen. It's always slightly nerve-wracking for me to be introduced by someone from the Today programme because there was a famous moment a couple of years ago when Jim Naughtie got my surname wrong by one letter. Just for a very brief while, I was the only cabinet minister who, when I went on to the Today programme, the presenters were actually more nervous than the cabinet minister, but those times have passed. But thank you very much for inviting me this morning. It's a great pleasure to be here. And I, as you know, am new to the health world after taking on this brief in September. And I always feel very humbled talking to audiences where people have spent their whole life in the NHS. And I'm reminded of the story of the argument between the doctor, the engineer, and the politician as to which was the most important for the future of humanity. And the doctor says, well, of course it's us doctors, because without us doctors, how could mankind have survived all these millennia? To which the engineer said, yes, but without us engineers, who would have created order out of the chaos? To which the politician smiled and said, yes, but who created the chaos? And I think that is perhaps something that's been said to one or two health secretaries over the years. But when I took on the job, I said that it was the biggest privilege of my life. And I feel that more today than I've ever felt it. 1.7 million people giving their lives to the NHS directly or indirectly. Bill Clinton said that politics was a bit like working in a graveyard. There are lots of people underneath you, but they're not necessarily listening. And I think that may be true in my job, as in many others. But I have been very conscious of the pressures the NHS is under, and the first thing I want to do is to say a very big thank you to all of you, because I think the NHS is performing extremely well in very challenging circumstances. If you just look at the raw figures as to the activity in the NHS, compared to 3 years ago, we're doing 400,000 more operations every year, 1 million more people going through A&E, which I'll talk about a bit more later, 3 million more outpatient appointments, and waiting times have come down in that period. MRSA rates have halved. We've virtually eliminated mixed-sex wards. There is all of that happening on essentially a flat budget. And that is because people inside the NHS are working extremely hard. And I've seen that for myself a huge amount. As part of the Francis report, you will have seen that the Department of Health itself came in for quite sustained criticism for not knowing what was going on its own front line. And so we've put together a scheme where all civil servants in the Department of Health are being asked to go onto the front line for a month a year. And we'll be the first government department to do anything like that. And in order to set an example, I've been going out myself most weeks, not just visiting the front line, but actually rolling up my sleeves and taking part. So I've been a housekeeper in Worthing Hospital. I manned a GP telephone line in Kennington. I sat behind the reception in A&E at UCLH. I was a porter in Newham. I did hourly nursing rounds in Salford. I did photocopying in George Eliot, thank you guys. I did washing down the beds in Watford. I haven't yet been asked to stand in for a heart surgeon, so no clinical roles involved in this. But I would say, from what I've seen, that people in the NHS have never worked harder. And I think we, as the leaders of the NHS, need to give them huge credit for that, because there is a huge amount happening and people are really showing incredible commitment to something that they believe in. So this morning, I thought I would talk about the two things that are really on everyone's mind at the moment. The first is the pressures in A&E, and the second is the Francis report into what happened in Mid-Staffs. And let's start with A&E. And I think, the first thing to say about A&E is there are huge pressures, but I think there have been some heroic efforts. And right now, we are hitting our A&E targets. In fact, we've been hitting them for the last 5 weeks. We had a difficult winter and a colder than usual Easter. But I think all of us recognise that A&E is the barometer for the whole health system. When things go wrong anywhere else in the health service, it tends to show up in A&E, and that is, I think, essentially what's been happening. And so what we've been doing is we've put in place some short-term measures, which are, I think, going to make a difference. The urgent care boards that NHS England has set up, giving hospitals a say in how any money that's withheld from the 2009 baseline levels is actually spent to help prevent admissions. And I hope that will make a difference. But I think we also need to recognise this isn't just about the 4-hour targets. It's also about what happens in A&E departments before you get to that 4-hour point. It's about the elderly lady with dementia who turns up in an A&E department in the middle of the night. No one knows her medical history. Perhaps she shouldn't be there at all. It's about the fact that in most A&E departments you can't access people's GP records and know their medication history, which makes the jobs of clinicians much, much harder. It's about the people who might not need to be in an A&E department, but when they go to an A&E department take up a huge amount of time because we haven't made alternatives easier. And if we're going to really fundamentally deal with these pressures, we have to look at those underlying causes and address those as well, which is why, together with NHS England, we are putting together a strategy focused on the group of people who, if we help, we can also do the most to relieve the pressure on A&E, and that is vulnerable older people, the people who are the heaviest users of the NHS, people with multiple chronic long-term conditions. And so we are putting together a vulnerable older people's plan with 3 elements, and we would welcome your input into that plan, which we hope to conclude by the autumn and implement from April next year. So what are the 3 elements of that plan? Well, the first is to actually look at what the emergency care proposition is. And Sir Bruce Keogh is leading a review of that. He's looking at the interrelation between GP surgeries, urgent care centres, A&Es, the 111 helpline, and just asking the question as to whether our urgent and emergency care proposition to the public is the right one at the moment. And I know you've been having a debate this week about reconfigurations, and part of that issue that we have to address is that we have failed to give the public confidence that there is anything in between a GP surgery and an A&E. And what Bruce's review will be looking at is how we deal with that issue, because we know there need to be many alternatives to those 2 ends of the spectrum. So that's going to be one very important element. Then we need to look at something else that people in A&E departments constantly tell me is a problem, which is the issue of not being able to admit people because the hospital beds aren't free, even though, as one hospital told me last week, they reckon that fully 2 wards were full of people who actually could be discharged, but they weren't able to discharge because they couldn't get into the social care system. And so that issue of integration of services, which has been something that's been talked about, I think there's a great deal of cross-party consensus on the need for more integrated services. But if we're going to achieve that, we need to break down the barriers to joint commissioning with local authorities, to the barriers such as the way the payments by results system work that create disincentives to joined up services. So looking at integration and making some real progress towards having joint commissioning of services and a more joined up approach will be the second very important element. And then the third part of the review, which there's been a lot of debate about in the last few weeks, is making sure that we have good primary care alternatives to A&E where they're appropriate. I know there's been a lot of discussion about the GP contract, but I think it would be wrong to say this is only about the GP contract, although that must have an important role to play in any debate. The way I look at it is this: if you look inside a hospital at the trouble that is taken at any handover, doctors and nurses recognise that when you're moving someone from one part of a hospital to another part of a hospital, when you are moving from one shift to another shift, that is actually the moment of greatest risk for the patient. And people take enormous trouble to make sure that those handovers or handoffs are done properly. Then if you look at the handover which has the greatest risk of all, when we actually discharge someone into the community, what sort of coordination happens? And the question I want to ask is, for the most vulnerable older people who are not leaving hospital cured, they still have those chronic conditions. They're likely to need the help and support of the NHS on an ongoing basis. For those people, who is the accountable clinician when they are outside hospital? And for me, as a member of the public, I would like that to be my GP. And I think that many GPs would like that too. I think we need to rediscover in a modern context the idea of family doctoring, where you have doctors in the community who know what's happening at any one time with their most vulnerable patients. And that I think is the heart of the debate we need to have about reforming primary care, to make sure that for our most vulnerable older patients, there is always an accountable clinician outside hospital, just as there's always an accountable consultant inside hospital. So we will bring those strands together. And the promise I want to make to you is that as you battle day in, day out, and I know how important it is and how tough it is to deal with the pressures in your A&E departments, we too are thinking about the long-term causes, the long-term issues, and making sure that we're addressing the tough issues that mean that going forward 2, 3, 4, 5 years, we are actually making sure that we move A&E departments in hospitals into a sustainable long-term place. So that's the A&E issue. Let me move on to mid-staffs. Now, I don't think anyone can underplay the horror of what happened in mid-staffs. And I don't think anyone is trying to say that this was only an issue that happened in one hospital, in one place, in one unique set of circumstances. And I do want to thank everyone for the incredibly honest way that the NHS has approached the issue of mid-staffs. I think all of us have looked at what we're doing in different parts of the NHS and started asking the difficult questions. And I think that's the first achievement. The second achievement is to make sure we actually do something about it. And there are still many, many areas where there is much work to do. There are still too many places where the patient is not first and foremost in the considerations of the institution where they're being looked after. We still have, last year, 299 never events. So that included, for example, 26 examples of a wrong implant or prosthesis put into someone's body. It included 62 wrong site operations. It included 115 occasions where a foreign object was left in people's bodies. So if I just put that another way, once a fortnight we're putting the wrong prosthetic into people, once a week we're operating on the wrong part of someone's body, and once every few days we're leaving the wrong thing inside people's bodies. And that is totally unacceptable. No one in this room wants that to be part of our NHS, and we do need to have a totally different attitude and culture towards safety. And we have got the world's leading expert on safety, Professor Don Berwick, who's doing a review at the moment to help us understand how we can change that safety culture. The other thing that I think we need to tackle is the variation between different hospitals, which is still much too high in terms of clinical outcomes. The highest risk emergency surgery has a mortality rate that varies between 20% in the best hospitals and 40% in the worst hospitals. That kind of variation with modern communications, modern sharing of best practice, peer review, shouldn't be happening, and we need to do more to tackle that. Now, how we approach this and how we change this is not going to be easy, but I think the heart of the problem is that we have had too narrow a definition of what a successful hospital is. The 4-week A&E target, the 18-week waiting time target, these targets matter, they're important, but they're not the only thing that's important. And what we need is to have a holistic view of what it is that defines and makes a great hospital. And that's what the new inspection regime coming together under the leadership of the CQC is designed to do. And I know there's a lot of nervousness and worry about how that will work in practice. But let me say this, it's really designed to make sure that there's one definition of success for hospitals that is shared by the professionals who work in the hospitals, shared by the public, and shared by the system, so that everyone is pushing in the same direction. And I'm sure that all of you are as delighted as I am that Professor Sir Mike Richards is going to become the country's first Chief Inspector of Hospitals, starting later this year. And with his clinical experience and credibility, he will make sure that the way that that inspection regime works has the support and backing of clinicians. And I think that will make a big difference. Now, at the same time as we have a new inspection regime, we have to be very conscious of the pressures on people working in hospitals in terms of bureaucracy and form filling. So I'm delighted that Mike Farrer is doing some really important work with Kingsley Manning, who's the new chairman of the NHS Health and Information Centre, with the objective of reducing the bureaucratic burden on hospitals by a third over the next few years. So the intention is that with a new inspection regime, we have less bureaucracy and not more bureaucracy. That will be a challenge, but I think it's one that's very important to focus on. Finally, let me just finish by saying this. I think when you talk about the A&E pressures, when you talk about mid-staffs, it's easy to get the impression from reading the papers of an NHS on the brink, an NHS facing an existential crisis. I don't believe that at all. I was in America earlier this week, and I was talking to the American Health Secretary, Kathleen Sebelius, about the challenges that they're facing in America. And one thing that comes across when you talk to different governments in different countries is the challenges that people are facing up to are the same in all countries. The challenge of containing costs, the challenge of prevention, not cure, the challenge of innovation, the challenge of how we cope with an aging population. And when you think of those big challenges, the kind of challenges we need to address if we want the NHS to be there doing its job fantastically well for our children and our grandchildren, I think we have the ingredients to be the very best in the world. Let's look at cost control. The NHS is recognised as being the most cost-effective system of healthcare delivery in international survey after survey after survey. It does it incredibly well. If you then look at the whole issue of prevention rather than cure, if you look at our traditions of primary care, of general practice, At their best, they are the very best in the world. And if we can find a way of rediscovering that, then we have every opportunity of showing the world how prevention rather than cure can become a reality. On the same basis, this is the country that invented public health. The whole business of clean water to stop the cholera epidemic, that all started here, and we have huge traditions in public health as well. Then there's the question of innovation. And this is a country with our life sciences base, with our clinicians, the country that unlocked the secrets of DNA in 1953, that invented or did the research to allow the invention of MRI scanners, of CT scanners, IVF. Still have the best surgeons for cancer, cardiac, pediatric, and many other specialties in the world operating in this country. And then you look at what's coming. I hesitate to talk about NHS IT projects, but 50 million records online, which is something that we are going to deliver. It needs to be delivered. If you then think about the implications for patient care of having a single medical record that you can access anywhere at all in the system, and us being the first country in the world that delivers that, alongside the fact that we'll also be the first country in the world to map 100,000 genomes, the implications in terms of disease prevention of being able to map a whole genome against someone's medical history so that you could see someone who develops bowel cancer in their 70s, what was happening in their medical history in their 40s or 50s. These are completely mind-blowing and have been compared to the kind of confluence of events that happened at the start of the internet. And then finally, the challenge of an aging population and how we make Britain the best country in the world to grow old in, where I think we have at our disposal something that no other country has, which is the values and the people who work in the NHS. That commitment that we've had in this country since 1948 to universal coverage, which is only now just happening in America, that is something we can be incredibly proud of. So I think if you put all those things together, we have the ingredients to do something truly remarkable in this country. If we aim to be average, we only ever will be average. But if we aim to be the best, we really can be the best. And I want nothing less for our NHS. Thank you very much.
We've got a bit of time for questions, and I'm going to come out in a few minutes to get questions from you. But before I do, I just want to start actually with this idea that you said the NHS is not on the brink. But we heard yesterday from, a very rare thing that the Royal Colleges, the NHS Confederation, and the patient group NHS National Voice coming together to say, look, we need to talk about serious change if the NHS is to survive. And the change that they're talking about would suggest that you could end up with 20 hospital closures or the equivalent. And I wonder if you recognise what they are suggesting. Do you accept what they said yesterday?
Well, I think we do need to innovate and we do need to change. But I think that if you say that unless we close 20 hospitals, we're not going to deliver this, then you will lose the support of the public for those changes that you need to do. And I think the way we need to do this, the reason why we have been so spectacularly unsuccessful in persuading the public of the need to downgrade or have fewer A&E departments is because they don't believe there's going to be an alternative there that's going to look after them as well. They think they understand what a GP surgery is, and they understand what an A&E department is, but they don't have confidence in anything in between. So what I would say is that the case for change is very clear. London is the best place in the country to have a stroke now because we have reduced the number of hospitals doing strokes from 32 to 8 and halved the mortality rate as a result. But we have to be better at making that case.
Okay, but you'll know, and many people here would say, that the reason the public don't have faith is because their politicians are sitting alongside them saying, no, we won't close that hospital. When as a result of changes, there is a logic to closing that hospital.
Well, and we as politicians have to be responsible in our attitude towards hospital closures.
And do you accept that politicians have not
or
been?
Service changes. Well, I would say that local politicians have long traditions of campaigning for local hospitals, but what we have to do is to be better at making the argument for service changes that are going to improve the lives of their constituents. So are you saying that we've failed? I think politicians have failed. I think the NHS has failed as well, actually, to make that case to the public. Do we need to find a way of making that case? Yes, we do.
But is the reality of the situation that you will never, for example, be able to close a hospital in, for example, the next 2 years running up to an election?
Well, I don't think anyone is talking about hospitals closing in the situation we are facing. What people are actually talking about is service reconfigurations so that we can achieve what we've achieved for stroke in London, so that where you have complex needs that are better treated in fewer places by specialists who are doing more operations every day and therefore getting better at it, you have better mortality outcomes. Now, let me say this to you, Sarah, and you're very good at interrupting, so I want to finish my point. I don't have any problem persuading my constituents that they won't always be able to get every service they need at their local hospital. And actually, I think the changes for stroke have been a model of how it is possible to persuade the public to do that. But I think if you go in and say, this is what we're going to do, we're going to downgrade these 25 services in different parts of the country, what you will do is destroy the public confidence because you haven't made the case properly.
I'm going to interrupt you to let some of these people,
do.
as I always do. We've just got a few minutes. First of all, let's start with microphone 4. Can I ask you, can you keep it short, concise, and perhaps say who you are, is it?
Thank you. So, Lisa Rodriguez, I'm Chief Executive at Sussex Partnership. I've been doing that job for 12 years, Secretary of State, and this year is my 40th year in the NHS. I started nursing in October 1973. So, very briefly, thank you very much for what you've said, the positive things you've said about what we're doing. Things are very tough. And what I would ask you, and it builds from what Sarah has just been saying, is can you form a coalition, please, Secretary of State, not just with members of the coalition government, but with members of the opposition, so that when we do make that case for change, when we make it well, and when we have patients, and when we have members of the public, and when we have members of the professions, and we have the leaders of the NHS all agreeing that change is needed to be made, when we've made that case for change, can you please support that case for change and not allow politicians to get in the way of what we need to do that's going to help the patients of the future? Can we ask you to do that?
Well, listen, I think the way you achieve things is by getting as much consensus as possible for all the changes you want to make. But it is extremely difficult because we have a tradition of oppositions, and I hold my hand up that my own party has been responsible for this as well in oppositions who just oppose every single reconfiguration. Now, at the moment, Andy Burnham says, and Liz Kendall say that they won't oppose every reconfiguration if there are good clinical reasons. But in practice, they have opposed every single reconfiguration that's been on the table. And so it's a very difficult thing. But I think we do have to make that case. And what I would say is that I think that the arguments that you've been putting forward and many other people have been putting forward is actually changing the public's mind. I led the campaign to save the A&E at my local hospital, the Royal Surrey. And I think the argument has moved on a lot since those days. And I think the public do understand the need for specialising complex surgery in fewer places. I just think we have to be better at making that case.
But you're not above your own political point scoring, not least with over the GP's contract. So,
well, I completely disagree with that. I don't know if you read my speech, Sarah, on the GP contract, but I actually...
were you unfairly represented on what you said?
Well, I do think there were some fundamental mistakes in that GP contract, and if I want to change the GP contract, I think it's my job as Health Secretary to say what those mistakes were. And the mistake, I think, was by removing responsibility for out-of-hours care from GPs, we broke that personal responsibility that GPs have for people on their list 24/7. No, I just want to, because you said that was point scoring. What's point scoring about that?
Well, I suppose the question was about a coalition, and I wonder if you feel that perhaps more could be achieved within the NHS if there were more consensus between politicians and you took some of the politics out of it?
Well, every time there is a change that you want to make, if it's the right change and you argue for it, and the GP contract is a good example of that, then I'm afraid it's not totally within my hands if other politicians decide to oppose that. But what I would say is, and I think it's really important, it is my job to argue for change. And I don't think you can have it both ways. You can't say that I'm not sticking my head above the parapet and arguing for change in one area, when if I do that in another area, it's then accused of being party political point scorer.
Number 3, and then we'll come to 4.
Deborah Mackenzie, Public Health England. I'm really interested in how you see the health and wellbeing boards helping you deliver on this ambitious agenda you've just set out for us. And you talked about integration. I'm also interested in going beyond integration, the role that you feel they can play.
Deborah, nice to see you. And indeed, Deborah's someone I worked closely with on the campaign to save the Royal Surrey Hospital many years ago. What I would say is that actually, going back to the earlier question, I think integration is an area where there is a great deal of cross-party consensus. And I think the health and wellbeing boards have an incredibly important role in bringing together local authorities and the NHS for joint commissioning of services for vulnerable older people. And I think that's a very big opportunity. I think there's very big support for that. It could easily be an area...
Andy Burnham's right on that.
Well, I think Andrew Lansley was right to set up health and wellbeing boards, Sarah, if I may say. But what is interesting is that Labour could have said, these health and wellbeing boards are Andrew Lansley's creation, and therefore we're going to oppose them on principle. But they're not saying that. They recognise that actually they do have an important role in integration. So I think there is perhaps more consensus under the surface than sometimes appears.
Microphone 4.
Yeah. Phil Gray, Chief Exec, Chartered Society of Physiotherapy. And first of all, to welcome very strongly the commitments that you've made, Secretary of State, in the speech there, but ask you to address 2 things, both a change of language and a change of services, and ask you to ask politicians and the media to stop using, in terms of language, the issue of older people being stuck in hospital, the appalling term bed blockers. They're not bed blockers. They're not there because they want to be. They're not there because they think it's the Costa del Sol. They're there because the system has failed them and they are stuck there. And secondly, in terms of the change of services, yes, warmly welcome the push towards prevention, early intervention and rehabilitation to keep people independent, keep them out of hospital and there, but actually to ask, can we actually see some investment in those services?
Well, I think I agree with both those points. And I think we do need to change the language in the NHS to be much more patient-centred. And that's why when we were working out how we should think about this plan for dealing with the long-term pressures on A&E, we decided to call it the Vulnerable Older People's Plan, because in most of the A&Es I went to, they said that if you could deal with this issue, these vulnerable older people with complex long-term conditions who come into A&E departments who probably shouldn't be coming into A&E departments, that is the single thing that would do the most in terms of relieving the pressure. And so by focusing on thinking on the people rather than the processes, we're hoping to do that. So general point I totally agree with.
Stan, is there any more money for A&E? Or have you argued for any more money just to alleviate the crisis?
Well, I don't want to get into a Today programme style interview on this, so I'm very happy to if you want to. But we have protected.
You can just say yes or no.
Nobody wants. Well,
sorry.
Do we need more resources in A&E? Yes. Yes, we do. We need more doctors in A&E, but we need more resources in many parts of the NHS, and these are very difficult financial circumstances. Should I, as Health Secretary, be actually mandating how much is spent in every single department of every single hospital? No, because we've tried that before and it doesn't work.
Okay, I'm running over already, but let's take one more question. Microphone 1.
Andy Cowper, Health Service Journal. Secretary of State, you talked in your speech about rediscovering the tradition of primary care as being the best in the world. Do you think there is a problem with the quality of primary care?
I think that GPs work fantastically hard. I don't think there's a problem with the quality of GPs, but I think we have structures that don't get the best out of them. And if you look at a typical GP's day, they will have a series of 10-minute appointments, maybe some 5-minute phone calls sandwiched in between some of their appointments. And we make it, and you know, that starts at 8:30 in the morning and goes on till 7 at night or even later. And they are absolutely exhausted by the end of the day. But we have actually made it very difficult with that structure, and the contracts they have and the payment incentives they have all contribute to this. We made it very difficult for them to take a holistic view of the people on their lists and to actually think about the whole person that they're looking after, to case manage people who have long-term conditions, to make sure they're getting the right care proactively. We've made that very difficult because of the system. Do we need to address that? Yes, we must.
Do you slightly regret picking a fight with them because it was seen like that?
Well, I haven't picked a fight with GPs. I've picked a fight with the structures, as I've just said. What do you want me to do? Do you want me to not pick a fight and not face up to the issue that nearly every single A&E department I visited has talked to me about, which is that the reason they're under pressure is because they don't have good alternatives in the community which can look after them better. I think this is an issue we do need to address. Of course, political opponents will say, even people in the media, dare I say it, will say he's picking a fight with GPs. But actually, the GPs I speak to say, actually, this is why we wanted to become doctors. We believe in the principles of family doctoring. It's just too hard with the structures we have.
And just a final thought, you said you were so hugely privileged, one of the greatest privileged to take on this role. I wonder if you also felt a little bit hard done by that you have it at this time, which must be certainly not the easiest time to be Health Secretary.
Well, I think you know, that actually makes it even more of a privilege. It might mean I have a few more sleepless nights, but it makes it, you know, there are huge challenges, but the point about health is that it matters more to people than probably any other single issue. And I think to pilot the NHS through a period of great challenge, but also massive opportunity. I mean, I think the one thing I would say to you, Sarah, is that you know, I never get a chance on the Today programme to say what I said just then about the opportunity the NHS has to be the very best in the world. I really think it has that opportunity. I wouldn't swap the system we have for the system in any other country I've visited. But that means facing up to some very difficult challenges going forward, and that's what I'm determined to do.
Jeremy Hunt.